We'll get started here again. My name is Kevin Malone, and I'm the moderator for tonight's session. This is the third and final session for the topic of the arthritic thumb. And tonight's session will be predominantly based on a journal club style. I am joined tonight by Dr. Marco Rizzo from the Mayo Clinic, as well as Dr. Nina Su from Emory University in Atlanta, Georgia, as our faculty. These are our potential conflicts of interest, which have been mitigated and do not are not anticipated to pose any compromise to the integrity of the material discussed tonight. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. It does not endorse nor promote the use of any products or service of commercial entities. Equipment used in this course is for demonstration and teaching purposes only and with the intent to enhance the learning experience. So this journal club webinar will take a novel approach to principles of the arthritic thumb using an illustrative case and articles with no single correct answer. Faculty will discuss a variety of reconstructive options, all of which have their advantages and disadvantages. The discussion will then offer learning opportunities for surgeons of a wide spectrum of expertise, including those still in training. In session one, the faculty discussed more traditional methods of evaluation and treatment options for CMC arthritis, including ligament reconstruction, tendon interposition, and suspension plasty, as well as some of the goals of postoperative therapy protocols. In session two, more modern and sometimes controversial topics were discussed, including PRP injections, denervation of the CMC joint, as well as implant arthroplasty. And tonight we are going to use articles to kind of discuss a big spectrum of aspects of approach to management of patients with these conditions. At the end of this session, you will be able to evaluate and advise your patients regarding a variety of treatments, options for thumb carpal metacarpal arthritis. You'll be able to describe the appropriate clinical scenarios for less invasive non-arthroplasty options, as well as to apply the results and outcomes from available literature while discussing expectations from treatment with your patients. This is our agenda for this evening. We have three presenters each to talk about two of our articles, and then we'll have some time at the end for wrap-up and questions or discussion. And these are the articles that we will discuss tonight. I believe you have all been provided a list of these articles as well. There are upcoming AO webinar sessions. The next series will be on complex hand fractures, and you can see the dates listed there. And the session after, or series after that, will be on carpal instability, all with the same model of traditional webinars and then a journal club as a conclusion. Upcoming live courses in October. There is a Fellows and Chief Resident course that will take place in San Diego, which is really ideal for senior residents about to begin fellowship or those that are perhaps in fellowship, where we will discuss a cadaver-based course approach with some special sessions on preparing for fellowship and beginning of practice. In October, also in the Northwest, in Seattle, is a one-day hand and wrist fracture management course. Really designed for more junior residents, really good introduction to some of the principles of management of hand injuries. With that, I will stop sharing and invite Dr. Rizzo to begin with his presentation. Thanks, Marco.
Well, thanks, Kevin. I appreciate it. I guess we're sort of talking about thumb arthritis from the, let me share my screen real quick. Okay, so I start with a case. This is a 36-year-old female who's, has basal thumb arthritis and maybe an early arthritic process. She's quite disabled and frustrated, exhausted, non-operative treatments. And I'm going to start with the first of my two articles that is on the concept of extension osteotomy for basal thumb arthritis. And I was a resident in training when I first saw this article from Matt Tomeno looking at this technique for early arthritis. And they basically looked at 12 hands and had about 2.5 two-year average follow-up, and all of them sort of healed at about 7 weeks, and all were able to return to work and had moderate or complete improvement of their pain and a notable improvement in their functionality. So it's quite impressive in the context of a procedure that preserves the joint, but also, I don't know if my slides are moving on their own, but I'll have to try to control that a little bit better. So in this series, it really looks at people with early disease and ultimately quite successful results. And there's other studies that show the same thing. So it's not like this is the only article that shows it. And why does it work? Well, there's a couple concepts. One is it functions a little bit like a high tibial osteotomy. Patients with early erosive changes or chondromalacia or some cartilage loss on one side. They I'll have to control my slides here for some reason. It just seems to be going on its own. And I apologize for that. The other part of it is they think and I do believe there's a component of this, although I would argue it's not quite as stabilizing as the other article I'll discuss. And the concept that it has a stabilizing effect on the joint, which also makes sense in the context of changing the vector of force so that you're bringing it into more abducted position of the thumb so that ultimately, the thumb itself is more stable at the base. And that makes sense to me. And I actually believe that happens, but not to the degree of the other article, which I'll talk about. But if you go back 50 plus years, this is really the genesis of this concept. And this is from Wilson as a classic article looking at this osteotomy, how he defined it and how he actually presented it. But the patients were different in this series. These were patients who had end-stage arthritis, like this case here, a 62-year-old female who is a clerical worker and has an adducted, pain-free base of the thumb, but frustrated functionality. And these are the patients that he described in his cohort. And ultimately, the technique is the same for both. You make about a 5 millimeter wedge cut, effectively extending the thumb, and ultimately affecting about a 30-degree correction of the and it's quite simple. You want to make sure you have enough bone proximal so you can get fixation in the metaphysis, so don't make the cut too proximal. And if you make it too distal, sometimes it's a little bit wonky in terms of the position of the metacarpal. And try to preserve the volar cortex if at all possible. So this is what I did for this patient. You can do tension band, you can do K-wires, so you can plate. How you fix it isn't really as important as the carpentry. And you can see that the patient will have pretty good abduction of their hand after a procedure like this. Interestingly, you can also use it for people who have adduction contractures after arthroplasty, like after a Wilby or after an LRTI. So this is another example of a way to address MP hyperextension in a pain-free base of the thumb that has an adduction contracture and is an alternative intervention for rather than MP fusion, which is commonly done in this case. And this is a case where this is something I learned from Alan Bishop. And when I was a fellow, we had a case like his, and we actually wrote it up, and it actually does work for these patients. And here's a case example of someone like that. This is a patient who had a Wilby suspension plasty and an adduction contracture. And this is a nice schematic or photos of the technique, quite simple with the cuts and close the wedge. And this is her after fixation. So, let's go back to our first case, the initial case. This is what I did for her in terms of fixation and early post-op. This is her 1 year post-op, and she went on to do fairly well with regard to pain relief. In fact, I did her other side as well. So In summary, the extension osteotomy, I think, is a good treatment for early disease or end-stage disease with pain-free, and also patients who have an adduction contracture after a trapeziectomy. Any questions, or should I just keep going and then we'll talk questions after? What do you think, Kevin?
Keep going. No questions yet.
Okay, so the other article I'm going to wrap. I'm going to use this case to sort of discuss my other article. This is a 19-year-old male farm kid who's a wrestler and presented with a volar mass at the level of the CMC or STT joints. You can see on his MRI that there's a small ganglion. He had pain. At the time I saw him, and this was a good learning case for me. At the time I saw him, he felt stable. He had pain over the mass. I did operate on him. I removed the mass. It came back as a ganglion. His joint looked pretty good. I did a sort of a Wagner type incision almost, but not quite to the extent that I would do for more aggressive surgery. And I was able to inspect his joint, and his cartilage looked great, but his thumb felt stable. And my article is to talk about ligament reconstruction. This is a classic article from Eaton and Littler with the beautiful drawings of Dr. Littler, who there's actually a book out of his drawings that you could get from the Hand Society, which are quite incredible. Dr. Peter Carter did his fellowship with Dr. Littler and had a copy of the book that he showed me. And in this series, it was interesting. They had 18 cases. And this is, to me, the real take-home point. And what they're doing here is trying to stabilize the base of the thumb. And if you look at the progression of basal thumb arthritis, it usually begins with some kind of degree of instability, whether it be the volar beak ligament, which I believe is actually the beginning of it. And there's often a debate about which is the more stabilizing ligament. Is it the volar beak or is it the dorsal radial ligament? To me, I think that volar beak ligament disrupts. Which one is stronger and which one is more important for stability, we can debate, but I think that the aim of this procedure is to reconstruct that beak ligament before they become arthritic. And this is what this table shows. If you get them early, you're going to likely get them a happy patient. If you wait until they become arthritic or stage 3 or 4, it's probably not as indicated or as predictable an outcome. And that's what they concluded in their series. They suggested that freedom from pain were better if surgery were performed before there was significant articular damage. And that makes sort of common sense in the space of orthopedics. So unfortunately, this kiddo came back to me about 1 year later, and he had more pain again. He didn't have an obvious ganglion, but there was suspicion that it might have come back. But to me, he felt unstable. And so I opted to move forward with the ligament reconstruction. These are some pictures of the procedure. You harvest half of the FCR through a Wagner incision, and you expose the joint. You want to create a tunnel through the base of the proximal phalanx, base of the metacarpal to pass the tendon, and pass the tendon through, then suture it back to the FCR. It actually is a great procedure in the right patient. To me, in my experience, now I've had colleagues who say it doesn't work as well, but I'm a huge fan of this procedure for the right patient. And most patients that I've done this on have done quite well. There aren't many out there that you can catch early enough who have this symptomatic enough joint with no arthritis. When I compare these two procedures side by side, I have this sort of levels 5, 6 sort of algorithm that I use, that if they're a little bit over 35, or if they're over 35, I tend to favor the corrective osteotomy. I think there's too much damage to the cartilage, and I prefer to sort of try to offload the joint. But if they're under 30 or 35, I'll prefer the ligament reconstruction, all things being equal. Of course, I go in with a plan A and B, depending on what I see as well. But that's sort of a rudimentary algorithm that I follow in these patients. So I think that's it for me, and thanks for your attention.
Marco, those are great presentations. Thanks so much. There, we do have a question from one of the participants
Mhm.
who, brings up the point, and just for emphasis, the metacarpal osteotomies that you described, either in the arthritic setting or in the post-arthroplasty setting, you made a point of making sure that they were pain-free to do that osteotomy. But the participant has asked, are you worried about developing pain as a result of the change in the loading vector following osteotomy?
That's a great question, and thank God I haven't seen that. I don't know if anyone else has in their experience that doesn't, but it does not seem to be a problem. What I think happens to these patients that they autofuse, you can still see a little bit of a joint line, but most of them have little or no motion at the base of the thumb. So they're effectively functioning like a fusion. So as long as they're function in that manner, I don't think it matters the vector that you change. And those are happy patients too. I mean, those patients love the fact because many of them can't get their hand, they can't get around objects, they can't get their hand around these. And once you bring their thumb out of the palm, they are just very, very happy.
Well, and even in that one example you showed where the patient had a lot of MP joint hyperextension because of the
Yeah,
adduction contracture, you didn't address the MP joint just by simply getting the thumb more abducted. The MP joint tends to act a little bit better too.
it sure does. And, understanding how much MP flexion they have beforehand helps you, but many of them gain MP flexion, even if they're a little stiff with the MP, just because they now they can work it better. Uh, but yeah, it's wonderful to be able to leave the MP joint alone. Uh, that I think that's a much better way than having to. And when you can, many of them though, if they have pain, for example, Kevin, if they have pain after an LRTI, you have to address the LRTI. You have to address the base of the thumb, right? So in those cases, I don't think these are the right patients for an osteotomy after that surgery. They need to be pain free at the base of the thumb for this to be an option that I would consider.
Great. Thanks, Marco. Nina, you ready? You want to go?
You bet. All right, perfect. So I have no relevant disclosures. So I was tasked with, sorry, I just have to move this out of the way. I was tasked to talk about arthroscopic management for the thumb CMC joint, and this is the article that we're talking about. So obviously some background is that complete trapeziectomy in the literature has been reported to perhaps cause some negative sequelae. That includes reduced strength has been reported in the literature. Also, certainly what we worry about is that proximal migration of that thumb metacarpal. Now that we take out the trapezium, we have this empty spot. And then certainly as it subsides, then you might have some impingement on the scaphoid if it's very bad subsidence or the trapezoid. Literature also would indicate that perhaps patients are not symptomatic from that. And I think anyone who has done the surgery has seen the subsidence for LRTI or Wileby. And the patients have not been symptomatic. But as a result of those potential complications, certainly subtotal or partial trapeziectomy was proposed. And this is what this article is looking at. And it's plus or minus interposition. In general, there's various interpositions that you can do. You can tendon autografts, you can do gel foam, you can do dermal allografts as well. That's been reported, but this particular study wanted to look at reporting the outcome after first CMC joint arthroscopic debridement and interposition of an acellular dermal matrix allograft, the graft jacket, for the treatment of first CMC OA. So details, so the patient population of interest and under examination for these authors were symptomatic Eaton stage 2 and 3 patients, as indicated in the pictures on the right. Diagnosis was made by physical examination as well as plain radiographs. Inclusion criteria was all of these patients had maximized non-operative management and had decided to proceed on with surgical intervention. And then pre-op measurements that they obtained were, of course, age, gender, right or left hand, the occupation, what their main complaint was. They also got radiographs, the physical examination, grip and pinch, and range of motion. In total, they enrolled 17 patients, and that's what was reported for this patient. This is their table 1 for their patient characteristics. showing obviously a predisposition for females, as well as the occupations were quite variable. Some were house retired, so not doing as much manual labor, and some were manual laborers. So the operative technique that they reported, and this is from their article, they used predominantly the 1R and 1U portals, which would be considered the workhorse portals for this particular technique. They used 5 to 8 pounds of traction, and that's something actually most literature it would indicate, but actually you can use quite a lot more, and that's what over time I've progressively used more with no significant sequelae. They used a wet scope. I think most arthroscopic techniques can be done under dry scope nowadays, and I think that's what most surgeons would do. They also used a 2.7 camera. Most nowadays would use a 1.9. It just allows a little bit more freedom in there. They also used a 3.5 burr to, of course, shave down the trapezium. And they took out about 3 to 4 millimeters of excision and then placed the graft jacket after they had created that space. Postoperatively, their protocol was to follow up in 2 weeks. They used a forearm-based thumb spike abduction cast for 4 more weeks. So in total, they were immobilized for about 6 weeks, and hand therapy started at the 6-week post-op. And then physical examination finding was, of course, the CMC grind test, strength, range of motion, and patient-reported outcomes. When I do this procedure, I think one of the advantages of the procedure is actually to get you going a little bit quicker. So I actually have them out of all the immobilization by 4 weeks if I've put some dermal allograft in there. But I'm going to show another case where I do keep them in for 6 weeks, and that's variable. So if you look at the results, the grip strength preoperatively was 22.6, postoperatively was 18, pinch was about 5, and pinch postoperatively was 4, but 88% had no pain, which really, I think, for most patients with thumb arthritis, that's what they really want, is to not have pain. 100% of them returned to work for those who actually were working at the time, not retired. And 95% of the patients actually recommend they would go through it again. One patient had ulnar neuropathy, which was thought to be due to the block, not from the surgery itself. And this is just a picture that they placed in their article about how the graft jacket, how their graft jacket actually gets inserted. There's usually some you'll put some suture to help almost guide it in and shuttle it into the wound, and use like a mosquito or something to pull it through. So in conclusion, they found that clinical outcomes actually compared favorably to those of other series of Eaton stage 2 and 3 management options. So it demonstrated as a viable treatment option. As the literature would indicate, people have good results from various other procedures related to thumb arthritis, and this obviously compared favorably. So discussion in general, I think, is that arthroscopic management has a theoretical and real advantage of having preservation of the capsule as well as ligamentous attachments. Autografts are the gold standard, but acellular collagen scaffolds certainly limit the donor site morbidity. And then this method compares favorably to other historical controls. So I think this is a reasonable option for patients. So for me, actually, I typically had previously done LRTIs, and then when this technique came out, I converted for obviously my younger patients who were Eaton stage 2 and 3, so I could do a partial trapeziectomy for them, and the advantage is to maybe get them going a little bit quicker. Certainly, you can't do it for patients. I really didn't do it for patients had a lot of lateral subluxation, or they had a lot of MCP hyperextension. I didn't really want to do that, this procedure for those patients initially, but you certainly can. And then patients with the majority of these patients are female, so really friable skin, obviously you require some traction, so I didn't really want to do that for those particular cases. But this is a case where, as a 59-year-old female, left thumb CMC, super active, very healthy, non-smoker, really into sculpting and kayaking, had really 6 months of all the options. So bracing, splinting, intra-articular injections, also went to hand therapy, did topical and oral anti-inflammatories, but still continued persisting to have pain. Physical examination was positive, so had a positive CMC grind test, had a painful CMC hyperextension. They had no real MCP hypermobility, and it was stable to examination, and it was certainly tender over the area that we were worried about. So this was some of the preoperative radiographs for the individual. And this is kind of like the workhorse portals. That's my hand, but it kind of just shows like the location of 1R and 1U is just on both sides of your first extensor compartment. It's radial to the APL for the 1R and ulnar to the EPB for the 1U. I think those are the two standard ones you kind of always use. There are some modifications, certainly, and there are other portals that can help. There's also volar portals that can sometimes help with the debridement. Another one that's very helpful is the distal dorsal portal, which is ulnar to the EPL, and it's kind of within almost the soft spot between the first and second metacarpals. So it's very helpful for patients with a very large medial osteophyte. Sometimes you'll use the D2 portal to get to that. And this is just a cross-sectional anatomy of like what you're actually visualizing. Remember, these are very small joints. So the 2.7 is certainly possible. I prefer the 1.9 just because I feel like it's too tight with the 2.7. And so what I do, so marked in red is what my preferred technique is if I was going to do it. When I do this, I convert it to other procedures now, but irrespective, when I did this, I would use the 1.9. I would start with a 2.9 millimeter full radius shaver, get rid of all the synovial tissue. Then I would use a 2.9 millimeter burr. And then actually this 4.0 acromioblaster burr, which is typically the shoulder surgeons will have it. It actually has a little hood on it, which is great. So it just speeds up your resection much quicker than doing like a 3.5 or something. It makes a massive difference for helping speed up the case. So this is just some of like you landmark with fluoroscopy initially to figure out where your CMC is. You get your 2-instrument shaver as well as your camera in there. Then this patient had a D2 portal also placed. So we're just landmarking with a needle to make sure we have the right spot. And then the resection for that medial osteophyte tends to be very flat if you can get to it with a D2. And then 6 months postoperatively, doing very well, no problems. So case outcomes by 3 months was fully returning to work and full activity level. By 6 months, the Pahanji score was 10, and grip opposition and apposition pinch strengths were superior to the contralateral side. And then 6 month patient reported outcome scores where she was doing quite well. So she was very happy. Now for that patient, for instance, when they have the alloderm inserted, so I actually take them out of immobilization in 4 weeks. I think you don't have to use a acellular dermal allograft. And so this is a case where it was a 70-year-old female right-hand dominant, also had CMC arthritis, did not want to have the full trapezium out. So then we decided to do a partial trapeziectomy and we K-wired it. And so it almost acts like a hematoma arthroplasty at this point, just maintaining the space to allow the hematoma to form. For these type of patients, actually, what I will do is immobilize for 6 weeks fully before removing that pin. So this is just a little alternation. As with all surgeons will change every procedure. So that was just some modifications. This is the second paper that I was tasked to talk about, was the 5 to 18-year follow-up for treatment of trapezio-metacarpal osteoarthritis. It was a prospective comparison of excision, tendon interposition, and ligament reconstruction, tendon interposition. So again, various modifications to simple trapeziectomy has been reported in the literature. And then prior studies really have found no benefit with tendon interposition, really making sure, articulating that the trapeziectomy part of the procedure is really the key fundamental factor that causes pain relief for the patient. But then it's relative up prior to when this manuscript was published, there was relatively short follow-up for those other publications. So they wanted to investigate whether palmaris longus or FCR ligament reconstruction, tendon interposition improve the outcomes of trapezial excision for the treatment of basal joint arthritis after a minimum of 5 years. So they wanted to go a little bit longer, see the durability of the procedure. They chose to only look at female patients with symptomatic thumb CMC. Because of the fact that women are most commonly affected by this, their inclusion criteria was 92 to 2001, and they looked at Eaton stage 2 to 4. 153 women were enrolled. It was 174 procedures, and 88% of the cohort was actually assessed at 6 years. The operative technique they used was dorsal approach. They did a piecemeal excision of the trapezium. For the palmaris longus, when the patient was randomized to that, they took it and rolled it and sutured it to itself and then inserted it, versus if they took the FCR, they took 50% of the FCR tendon to loop and insert as the interposition. And then a unique perspective to this particular paper is they actually used the K-wire to hold the metacarpal base to the trapezoid index CMC joint. And then they remove that at 4 weeks. So I don't think that that's necessarily a standard procedure for most surgeons. So that is an important distinction there. And it's reported as one of the perhaps reasons why their excisions, simple excisions, did so well. And they were casted for 6 weeks. I also, for LRTIs and simple excisions, would immobilize for 6 weeks as well. So this is, again, their table one looking at the distribution, and they're very similar in terms of the patient populations. And regardless of what you did, the pain actually improved quite well with all 3 procedures. So that's trapeziectomy alone, trapeziectomy plus palmaris longus interposition, and trapeziectomy with the FCR. So results for key pitch, tip pinch, grip strength, there was no significant difference between operative and versus contralateral hand before surgery, 1 year post-op, 5-year post-op for all 3 groups. And there was no difference in opposition between the groups, and the complication rates were very similar as well. Not unsurprising given the fact that they all had very similar surgeries, just depending on whether they had something inserted. So their conclusion was after a minimum of 5 years, the outcome after trapezium excision is not improved by either tendon interposition alone or LRTI. And pain relief at 1 year was maintained. They actually found the deterioration of bilateral thumb key pinch 5 years, but similar in all groups, were indicative of perhaps aging in the patient. So over time, both sides actually kind of equilibrated, perhaps because the other side was also either becoming arthritic or more painful. And then there was variable patient-rated outcomes, but globally they all did relatively well compared to pre-op. They also didn't follow x-rays because they did not feel that subsidence necessarily correlated with clinical symptoms, and they weren't going to obviously revise things on x-rays alone. So they did not actually follow with x-rays. So this is a case, it's actually very hard. Like, I don't routinely K-wire for my LRTIs, but this is a patient who, 78-year-old female, right-hand dominant, retired, persistent thumb pain, post-trapeziectomy LRTI. So regular past medical history, had significant tenderness over the thumb CMC. So this patient actually had trapeziectomy with FCR, had pinning, had the K-wire removed, had some subsidence, had significant pain at the MCP, as well as the thumb index joint area, had injections, really didn't help, but really, as you notice, is getting a lot of subsidence. So unfortunately had a revision, but of course had the FCR redone because she did not wish for a suture button suspension plasty, and obviously has become extremely unstable. Eventually, the patient did quite well, had suture buttons suspension plasty performed. But this is an example of subsidence that goes really, really poorly, because I don't think most people would see this. So final thoughts really are that there's many described techniques for thumb CMC management. Open and arthroscopic options are available, and all options in the literature seem to provide comparable pain relief, satisfaction, and functional return. But subsidence and other complications are rare, but possible, and when they happen, patients are not very happy at all. Thank you so much.
Nina, thanks. Those are great presentations. And I have a question, actually. I'd love to hear your thoughts, and also Marco's, based on a participant's question. Certainly in Marco's presentations, he talked about, doing ligament reconstruction, and those patients are going to have some perhaps subtle instability, and that type of procedure can give them more stability and perhaps more longevity of their native CMC joint. But with the types of procedures, the osteotomy or the ligament reconstruction that Marco discussed, or, specifically for more of your arthroscopic technique, if the patients have frank subluxation of their CMC joint, does that rule those procedures out for you? Or do you have to do other supplemental work to make those type of options available to those patients?
I typically, if they have a lot of subluxation at the CMC, I typically do not like to do arthroscopic techniques. I think that makes them a bit more unstable and more unhappy. Dr. Rizzo, I don't know what you do for yours.
Yeah, I like, those are good patients. Provided their cartilage is okay, you have to sort of go in with a plan A and B with those patients, in my opinion. Inspect the cartilage and then be ready for another option. But I think the ligament reconstruction works pretty well with that. I will supplement with a capsular tightening if it seems indicated. Um, there's various types of capsular tightenings that have been described that have been quite effective for early arthritis as well. I'm blanking on the surgeon. He's from Oklahoma, and he had published on this, and I thought it was really, he had published pretty impressive results with it. So I'm just still blanking on his name. That's a senior moment I'm having. That said, I do think that if it looks lax, then I would supplement it with some fixation and probably immobilize them a little longer if I felt like I needed more scar benefit. If there's cartilage that's gone, I'll either consider an osteotomy or a frank CMC fusion, which I'm a huge fan of. So I would talk them through that potential option for the surgery preoperatively, of course, and have a plan A, B, and C.
Dr. Zavo is suggesting that perhaps you're thinking of Ghazi Ryan in Oklahoma.
Oh yeah, Ghazi Ryan, geez, and he was president of the Hand Society too. So, geez. Anyway, I got to get my medication. So.
The vault up there.
Thank you,
Okay.
Dr. Zavo. I appreciate it.
So I will bring us home here with the last two articles. So this is the first of the articles that I'm going to discuss, and it is a prospective clinical trial comparing denervation with suspension arthroplasty for the treatment of carpal metacarpal arthritis of the thumb, published in the Journal of Hand Surgery in 2023. The details of the study were that this was a prospective level 4 study, denervation versus suture suspension plasty, all performed by a single surgeon. This was not randomized. The patients were given a choice. And they had 48 patients over 19 months. And not unsurprisingly, a higher percentage of patients are going to try to choose the less invasive, perhaps earlier recovery procedure. The denervation group was younger than the arthroplasty group, but otherwise similar demographics between the two. And the final evaluation was done by assessing function with the Michigan Hand Questionnaire, pain with the Visual Analog Scale, and then quality of life with the EQ-5D assessment tool. And then for their denervation technique, they targeted the branches that have been described from the superficial radial sensory nerve, the lateral antebrachial cutaneous nerve, the palmar cutaneous branch of the median nerve, and then the deep branch of the thenar motor from the median nerve. Average follow-up was pretty similar, just under a year for both groups. And you can see here the denervation group on the left, the arthroplasty group on the right, in terms of improvements between both with pain, function, and overall patient satisfaction, all with pretty significant improvements. And then comparing the two, improvement in pain was 91% in the denervation group and 81% in the arthroplasty group. Function also slightly increased improvement in function with the denervation versus arthroplasty. A little bit more numbness at the incision as they're doing more nerve work with the denervation procedure, so not unsurprising there. But the arthroplasty group actually had more numbness at the distal thumb. And then significant difference in the time to recovery and return to activities in weeks, with 3.3 weeks for the denervation group and 18.3 weeks in the arthroplasty group. So, similar short-term outcomes with significantly quicker return to full function, again, 3.3 to 18.3 weeks in favor of the denervation group. Both groups, improvement in function and pain and quality of life. There was one revision in each group, but the authors did not describe what the revision procedure was for either of these individuals. So this study does show results that are similar to other studies with promising potential of denervation. It is ideal in younger patients without the CMC joint instability, perhaps with an earlier stage of Eaton arthritis. Other studies with longer-term follow-up, this one from recently published in Plastics and Reconstructive Surgery in 2026, looking at 30 months of follow-up, that over a quarter of those patients did ultimately undergo a revision CMC procedure. So perhaps this is a way to buy some time for these patients, but maybe not the end result, looking at some of these longer studies. I have a couple cases where I have attempted this, and this is a great result. This is a 76-year-old female, painful arthritis in her non-dominant left thumb, no CMC joint instability. She had multiple injections, activity modifications, NSAIDs, bracing, and even went to another hospital in town for a low-dose radiation therapy protocol that they were trialing there, and was unhappy with the outcomes for all of those and was unwilling to go through the rehab and recovery associated with more traditional arthroplasty options. So after 6 weeks after denervation, which was just a couple of weeks ago for me, reported significant improvement in preoperative pain level and function, just still a little bit achy at the surgical site. But she's a salesman and goes to trade shows and does a lot of handshaking, and she's very happy to be able to do that without pain, even at 6 weeks. And then as another example where maybe I tried to bite off a little more than I could chew, this is a 73-year-old male with arthritis of his dominant wrist and hand and thumb. He had failed conservative treatment, so we attempted a combined CMC joint denervation by a similar technique of those 4 terminal nerve branches, and then also tried to denervate his wrist joint with AIN and PIN neurectomy. And at 6 months, he reported that he was no better. And so he ultimately, at 7 months, was revised to an LRTI with a radioscapholunate fusion and then a wafer distal ulnar resection to decompress that ulnocarpal joint. Okay, my take is on denervation is it is a low-risk procedure that does not burn any bridges and may result in improvement in pain with quick recovery in the right patient. And so I think the right patient is certainly someone with CMC joint arthritis without instability. It's questionable as to whether the arthritic STT joint would be responsive to this same procedure. If they have MP joint instability, that may also be someone that a CMC denervation procedure may not be as predictable. And then patients with concomitant wrist joint arthritis, even with a wrist joint denervation, that may be someone who is less likely to respond, certainly in my limited but personal experience. Okay, our second article and final article of the night is this one, long-term outcomes in female patients with carpometacarpal joint arthroplasty and metacarpophalangeal fusion compared with the unoperative side or with CMC joint arthroplasty. And this was published last year in the Journal of Hand Surgery. And so the background here, and we've talked about it earlier tonight, the difficulties that are present with patients who have thumb MP joint hyperextension stability. And typically hyperextension stability greater than 30 degrees and or MP joint arthritis are indications for arthrodesis at the time of CMC arthroplasty. Allowing the thumb MP to continue to collapse into hyperextension after CMC arthroplasty will alter your mechanics across your CMC joint and may result in weaker pinch, worsening deformity, and early failure of surgery. Atrophy from median nerve dysfunction also will lose, those patients will lose their dynamic stability of the MP joint and CMC joint, potentially leading to the same failure mechanisms after CMC arthroplasty. So the hypothesis for this study was that MP joint arthrodesis with CMC arthroplasty would result in greater long-term pinch strength and quick dash improvements when compared to the unoperative side or to patients undergoing CMC arthroplasty alone. So this is a retrospective chart review, single surgeon, 14 years. You had 16 individuals that they assessed who had untreated contralateral CMC arthroplasty to a contralateral to a side that they operated on. They had 29 patients who underwent a CMC arthroplasty, and their technique was an APL suspension with fascia lata interposition. And then 41 groups, the largest group was CMC arthroplasty with MP joint fusion. And that fusion, it was the same arthroplasty technique, fusion done with compression staples. And their indications, as mentioned on a slide previously, are listed here. They did do a partial trapezoid resection for any patient in any of the surgical arms who had concomitant STT joint arthritis. But both the arthroplasty alone and the arthroplasty fusion groups followed the same postoperative course. And if the patients had less than 2 years of follow-up, they were excluded from final analysis. So they ultimately had 53 patients with 70 operated thumbs, meaning that 17 had staged bilateral procedures. 11 of the patients who had combined arthroplasty fusion on one side had a contralateral CMC arthroplasty. 3 patients had bilateral CMC arthroplasty with MP joint fusion, and 3 had bilateral CMC arthroplasties. So the group that underwent the arthroplasty combined with fusion had worse pre-op quick dash scores compared to the CMC arthroplasty alone, and these were statistically significant differences. Both group with significant improvement in quick dash from pre-op to final exam, and the relative improvement was greater for the combined arthroplasty fusion group than the isolated arthroplasty, and that also was statistically significant. The combined group fusion arthroplasty achieved greater pinch strength, 11.3 pounds, than either of the other groups. But they did identify, as I think Dr. Sue mentioned in her talk, that key pinch did tend to decline with age in all groups, regardless of treatment or non-treatment. And both groups had similar final VAS pain scores. So the conclusion here is that MP joint hyperextension stability will result in loss of key pinch strength and fusion at the time of arthroplasty, can result in significantly improved pinch strength compared to untreated untreated arthritis or patients that had arthroplasty alone. This combined group also had significantly improved patient-reported outcomes. They did not describe any non-unions, revision surgeries, or secondary surgeries for hardware removal related to the arthrodesis of the metacarpophalangeal joint. So here's a case of mine, a 63-year-old right-hand dominant female with long-standing symptomatic bilateral hand and thumb arthritis. She's got some resting MP joint hyperextension on the right, but dynamically went into collapse with pinch with greater than 40 degrees of MP joint hyperextension on both sides. So she underwent staged bilateral LRTIs with concomitant MP joint fusion and proximal trapezoid resection. And as you can see, I also added a DIP fusion of her left small and right index finger. And within several, by about 6 months after her second surgery, reporting significant improvement in all metrics, function, and she had already returned to all of her activities. So she was very happy, and that's, I guess, the best measure of a good outcome. So unrecognized and untreated MP joint instability can contribute to poor outcomes, early failure, and need for revision surgery after CMC arthroplasty. And in fact, most revision arthroplasty procedures performed, a high percentage in the published literature, do end up being combined with a MP joint fusion. I have found in my patients that concomitant MP joint fusion is an easier rehab, as they're not having to reestablish MP joint mobility, with a quicker recovery and a return to function. So that's it for my talk. Are there questions?
Kevin, one question from the audience, Dr. Megan. What do you consult your patients who want denervation in terms of expectation for duration of pain relief? And I welcome Nina's thoughts as well.
Yeah, so, this is something that I've, 3 years ago, 4 years ago, I wasn't doing at all, and I've probably only done it in a handful of patients. And I tell them we don't know. I say that this is a procedure that should be an easy recovery once the soft tissues are healed. And I think we will improve your pain, but I can't tell you whether it'll be a 20%, 40%, 80% improvement. And it may not be the last procedure you have.
Yeah, I usually say for my denervations, like, this will probably definitely not be your last procedure. But then, they always, if they really want numbers, I'll say like in 5 years, maybe 30% or so are having some type of recurrence. I'm kind of in the first boat. Like, I do this procedure, but I don't think I'm probably the one that does it the most. But I have had good results with it, funny enough. And it really is that very selected patient who does not want to have any or as minimal downtime as possible. So I think it's a great procedure. But yeah, I don't think we exactly know how long it's going to last.
Dr. Lipshay was at the IFSSH this I don't know if it was the IFSSH last year or 2 years ago. I'm trying to remember. Anyway, he presented at the IFSSH, and their experience at Hopkins was suggestive of, maintenance at 5 years of about 80 to 90%. my experience hasn't been quite as good. I like yourself, like Kevin. I don't do that many of them. And I've had several failures, so I'm not as enthusiastic about it. I'm sort of batting 500. We have Dr. Bamberger in here, so I wonder if Dr. Bamberger would chime in and give us his experience with denervation.
Exactly as yours, Margot.
Mhm.
It's like 50-50. So I'll just throw something out. I think we do denervation on most of the procedures that we do.
Mhm.
So I think there's a component of that. In the cases that you guys have talked about, I follow along perfectly. Yep, we can try this. We'll do this. Who knows? I throw in a scope. Why? I don't know. Just to kind of clean it up. I don't have a straight answer, but you kind of clean up the joint a little bit and denervate it, and then maybe you get 4 to 5 years. But I think it's like you said earlier, is that will you get good results in a person with a chevron osteotomy or an instability? Yeah, if you know the right patient for it, and I think that's the important part. So who is the right person? I'm not sure, but I think you can get some results. You can put them off a little bit and try to maintain the stability of the thumb.
Yeah, I don't want to go too far off on a tangent, especially since Dr. Zabo had a question as well. So, but I think a lot of the denervation concept is a bit about your enthusiasm can become contagious. I'm sure Nina's
Yes,
heard me say this
yes,
before.
yes.
So if you're an optimistic guy in general, I think you get better results. If you're worried about laying crepe and you're feeling like I got to sort of, I don't want to sort of oversell this, you're not going to get as good of results. I think there is a supratentorial contagious component to this. I don't care who gets the credit. If it's placebo, it doesn't matter, but I just don't have a good salesmanship sort of combined. Same in the wrist for me. I don't get the 80% outcomes with wrist denervation. I still do them, but I don't get the same results that Dick Berger got and have been popularized by others. But Dr. Zabo had asked, maybe Kevin, you could start with this one. When you're
Sure.
doing your MP fusions, do you think of using a neutral or slight flexion as your case showed, and maybe which one is better?
Yeah, I'll give you my answer, and I'd be interested to hear yours and Nina's and even
Mhm.
Brent's. I've always tried to put my thumbs in somewhere 20 to 25 degrees of flexion at the MP joint. And I think that gives us a good stable position, and it sort of maintains the CMC joint into abduction with key pinch. And I'm really trying to avoid allowing that CMC joint to fall into adduction following arthroplasty. And I think keeping the MP joint flexed helps facilitate that. I have no conflict of interest with the product that was shown. That sort of is free dials it into 25 degrees. It gives you good even compression across the joint. With some of my dorsal plate fixation, I have seen delayed unions, and fortunately not a non-union, but really waiting to see if some of these are going to heal. And in some patients, I've done tension band wiring, but I do like this implant that I showed there, even though it is quite expensive.
I would also agree. Like I like to do a little bit of flexion. I feel like the patients are a little bit better afterwards.
Yeah, I don't go quite as far in terms of flexion. I try to go, 0 to 10 at 15 most, largely because I've had this class before where if you have them too flex, they get frustrated. They can't get depending on how much mobility they have at the base, they'll get frustrated. They'll have trouble getting their thumb away from the hand.
Mm-hmm.
And I had a discussion with this with Andy Coleman, who had the similar experience, and he cautioned me because I had a patient came back early in my career who was frustrated. So I've learned to sort of dial out the extension. I haven't been burned by even fusing them in 0. I mean, that hasn't burned me, but I've been burned the other way when I overflex them. So that's sort of where I stand with it.
So mine is full homage to Bob Belsall. Bob said, put it in 0. I mean, what do
Mm.
we do? We basically pinch everything to the tip. So I try to put it all the way to the tip. I mean, you're not going to get, nobody really needs the motion to flex over to the other side. They're going to get some, but so I put it in 0 and maybe even a little bit abduction. Occasionally, I don't try to do that. It just may end up that way, and I'll get excited if it goes there. But putting it more zero than flexion.
Another question for you, Brent. Did you notice subluxed in the discussion from
No.
Dr. Zaba? Okay.
Subluxation, subluxing. It's something that Dr. Zabo has a passion about. So he and I have a little thing going back and forth. I'm wrong, and I would say I'm always wrong. When you have somebody like that, gentlemen, you just say yes, sir.
Okay, so I think we're pretty much ready to wrap up here. I do want to put these slides, see if I can do this again, just as a final plug here for our upcoming session. So again, in a couple of weeks, we'll start series 4 on complex hand fractures, talking about metacarpal fractures, phalanx fractures, and then a corresponding journal club. And then in October, series 5 is carpal instability. So looking at acute and then chronic carpal instability, followed by the journal club there as well. And then also these live programs later in the fall in San Diego and in Seattle. So if you're looking for a reason to go to the West Coast, maybe to get away from all the smoke and forest fires that we're getting in the Midwest and the East here.
So I'll just throw it out there. I'm sorry this was unprompted, but you should come out to San Diego because you're going to spend too much money to go to Boston, for the residents and fellows, and you're going to get all this freaking stuff from Canada. So come out to San Diego. We'll give you a better course. And
Dr. Bamberger and I are co-chairing that course, and we.
Oh, did I say that? I'm sorry. Disclosure. Yes.
Yes. We've got a good course lined up. All right, Marco, Nina, any final comments, thoughts?
No, Kevin, thanks for leading us, and it's a great discussion, great articles, and I appreciate the audience. Dr. Zabo, thank you, and thanks to the others who chimed in, helped make it a richer tapestry, if you will.
All right.